ci parla delle indicazioni tecniche per la fissazione delle giunzioni in età pediatrica. Quindi entriamo nel campo delle malformazioni complesse, non solo del chiari e basta.
Good afternoon. First, I wanted to take this opportunity to thank you and say how grateful I am to be able to participate in this Chiari Consensus Conference. I particularly am grateful to Dr. Valentini for inviting me here from Salt Lake City. I'm a pediatric neurosurgeon in general. I take care of children 99% of the time. A part of my practice is handling complex craniocervical problems, including congenital problems, tumors, trauma, and so forth. And we're really going to switch gears here from the previous talks. We're going to talk specifically about surgery because that's what Dr. Valentini asked me to talk about. And I'm going to begin by just discussing a little bit of the differences between the standard or simple type of Chiari that people have been talking about very eloquently for the last couple of days, and make a distinction with the complex Chiaris that we're going to talk about here in some detail. So it's quite obvious that the standard Chiari malformation is not so simple, and that's evidenced by all the different talks that have been given. And what we're talking about, complex Chiaris, are patients with scoliosis and syrinxes, retroflexive odontoids with brainstem compression, or occipitalization of the atlas, or other cranial vertebral anomalies, and even patients with underlying hydrocephalus. And this may be stretching this analogy a little bit, but I think the standard Chiari problem is probably not such a simple force as lava flowing down the hillside. But I think what we're dealing with complex Chiari malformations is a very complex process, and sometimes it's overwhelming. This is one of my favorite pictures. It's the Colorado River in my home state of Utah. But you're overwhelmed sometimes by the complexity of the issues that are going on. So I think that's not an invalid comparison. So a lot of these considerations have been talked about previously yesterday, that craniovertebral junction and basilar skull abnormalities can be seen in up to 50% of the patients. That's personally been my practice in Salt Lake City with clipophile problems, axis assimilation. We're going to talk about this in some detail. Maybe 10% of the kids have hydrocephalus, syringomyelia, about a third to half of the patients, and about 20% of the patients come from typically orthopedic surgeons for scoliosis, non-idiopathic scoliosis. And so the radiological imaging I sort of tailor depending on what's going on with the patient. If the patient has a simple Chiari malformation, sometimes I'll just stop with just the MRI and follow them clinically, but many times they require more imaging, CT scans, plain films, special MRIs, including complete spine MRIs. So the goals of standard Chiari surgery are, obviously people have been talking about this over and over, is to enlarge the posterior fossa and recreate the cisterna magna, thereby permitting normal flow of CSF from the posterior fossa to the cervical subarachnoid space, and I think that's a very valid point. But when you talk about complex Chiari surgery, there are other points that come up also. You have to perform adequate brainstem decompression, and if it's present, you have to eliminate or reduce syringomyelia by performing an adequate decompression and stabilize or improve scoliosis. So these are all other important factors. And I think another one, which is also important from my point of view, what I've sort of strived to do over the last 15 years, is to avoid the use of haloorthoses and so forth. And I've had a lot of success in this over the last couple of decades. And this is a patient, obviously from 2006, who had undergone a stabilization at another hospital. And this is something that it's no fun to have a halo on for 4 to 6 months. So being able to handle these complex problems without the halo, I think, is a good thing. This is a typical flow diagram for surgical decision making. This happened to be published in 1995 by Rich Ellenbogen from Seattle, Washington, and I think this is very standard. What we're going to do is focus primarily about this right-hand side of the graph. And it's just 2 boxes here: significant ventral compression of the brainstem, transoral resection of the compressing structure. So we're going to expand on that a little bit, and we're going to talk about that in some detail. So simple Chiari malformations can be handled by a variety of procedures. We've all heard this in the last several talks. Just bony decompressions and duroplasties. Duroplasties and arachnoid opening and shrinking down the tonsils. That happens to be one of my favorite ways of handling it. And as the previous speaker was just talking about, and the ones before that, these decisions for each procedure can be driven by either intraoperative Doppler ultrasound results or even electrical monitoring. So obviously, there's several studies going on right now in America trying to compare these different procedures head to head, but there's nothing that's been published so far. And initial results with only bony decompression were very promising, but several studies described about a 10 to 20% reoperation rate for persistent symptoms or persistent syrinxes. However, about 85% of the patients get well and do much better in carefully selected series. And I think that's been shown time and time again. So for complex Chiaris, what are the overall surgical indications? And I think there's three. One is symptomatic brainstem compression, and obviously syringomyelian scoliosis. But what are we talking about symptomatic brainstem compression? Where does it come from? So retroflexodontoids, osteogenesis imperfecta it's fairly common in that disorder. Other congenital vertebral anomalies like civilization of the atlas clipophile and Langer-Gideon syndrome. And it's possible even after posterior decompression with patients with inherent or incipient instability, you can tip them over the edge and they need stabilization. So what are the indications for ventral decompression, doing it some sort of odontoid resection? Obviously, symptomatic brainstem compression include bulbar findings. Sorry about the typing there. But so, what are the bulbar findings? You're seeing a patient in clinic. What are the questions you're going to ask them? Are they having difficulty swallowing? Typically, patients with severe brainstem compression have a difficult time handling thin liquids, and they prefer, or even solid foods, and they prefer yogurt or cottage cheese or things like that. And that's a very, very common finding that I find very interesting. I think their oral motor capabilities handle that semi-solid material much better. Sleep disorders are very common. I see many patients referred from the Sleep Disorder Center. Tonal speech dysfunction. Patients come in with a very characteristic high-pitched nasal type of voice, maybe not unlike me with my cold today, but and then aspiration pneumonias, especially recurrent ones, are definitely a sign. Tongue deviation is obviously a clinical sign. And then myelopathy with sensory motor disturbances, balance and coordination difficulty, gait dysfunction, and reflex changes. So what are the indications for stabilization and fusion? And I just talked about patients who have inherent instability. It's fairly uncommon in patients with Chiari 1. If they have a congenital vertebral anomaly, they can have a little bit of underlying instability, or Ehrlich-Danlos is another one that it could occur in, but it's usually part of some type of congenital vertebral anomaly. And many times these problems with inherent instability can just be handled from a posterior direction alone with the stabilization and fusion. Of course, if you go transoral or do some type of odontoid resection, we're going to talk about that, you do that as part of the Chiari decompression from the back. You always destabilize the patient. You break the C1 ring in two positions. We're going to show pictures of that. And the patient is extremely unstable at that point. Or instability after posterior decompression. I've had a couple of patients that my partners have sent to me where they've gone ahead and done the posterior decompression and they've unmasked an underlying instability. So this retroflexodontoid, it's also called dolichoodontoid, and there was a paper published in 1999 describing a line that goes from, it's the clival C2 line, so from the tip of the clivus to the back, inferior posterior portion of C2, the perpendicular line between that line and the brainstem is measured. If it's 9 millimeters or less, you can probably get away without doing a transoral resection. 9 millimeters or more, people would recommend a transoral resection. Obviously, that's just a loose recommendation, but it has borne out over the years to be a fairly useful indicator. So if you see a patient with a retroflexed odontoid, what do you do in this situation? These questions go through my mind. So obviously, is there brainstem symptomatology? And if so, to what degree? Mild, moderate, severe? And if you did a QR decompression from the back, what is the chance that the patient will improve, ultimately worsen, or if you make them unstable? And if you did a transoral resection, does that commit the patient to a posterior decompression and fusion? And most of the times that answer is yes. There was a recent paper out of the Barrow Neurological Institute in Phoenix, Arizona, published in 2004, where they took 8 patients, and with mild retroflexed odontoid, they were able to relocate them in a slightly extended position in a one-stage procedure with a QR decompression and instrumentation and fusion. So it's one way of handling it. I haven't necessarily done that way myself, but it's out there and it's been published, and it's something to consider. So here's a patient. So this is an interesting girl. She's 14. She came with significant brainstem findings and myelopathy, high-pitched nasal voice, swallowing difficulty, and so forth. You can see she has a retroflexed odontoid, but not that bad. It's not that bad when you look at the sagittal CT scan here. When you look at the MRI, she has significant ventral compression. Some of this, I think, is inflammatory tissue or pannus from some type of inherent instability. It's the body's way to try to stabilize that joint. I did inflection extension films on her before surgery, and she wasn't unstable, interestingly. And she didn't have a congenital vertebral anomaly. She didn't have occipitalization of the atlas. So, and then I put her into traction to see if I could do a one-stage posterior procedure, and it actually made her worse. And she had significant myelopathic symptoms at 10 pounds. So what to do? So I decided to go from the front with a transoral odontoid resection. And then I did a standard, basically it's 3 operations in one. You do the transoral. I usually do that on one day. And then I let them wake up, and then 4 or 5 days later, in the interim, I keep them in a hard cervical collar, and then let's say I do the transoral on Monday. On Friday, I'll take them back to the OR, and we'll do the posterior part with a posterior fossa decompression, C1 laminectomy, duroplasty, and tonsillar shrinking, and then we'll perform occiput to C2 instrumentation and stabilization, and then the arthrodesis with a rib graft. And we're going to talk about why you need rib and not other material. So here's another problem with occipitalization of the atlas, and this has been shown. This is shown very eloquently yesterday with some of the radiology and the embryology discussions about how C1, the lateral mass of C1, is fused to the occipital condyle. And these patients, every single patient I've seen of this is a teenager, usually teenage boys. And usually it's associated with Klippel-Feil or Langer-Giddings syndrome or other congenital vertebral anomalies. I don't think these things are pathological in and of itself. It's interesting listening to all of the data that Dr. Miller has. But it creates an abnormal craniovertebral relationship that leads to a carry 1 malformation somehow. I don't know how, but it happens. And we see a patient with occipitalization of the atlas. The first thing you think is carry malformation, in my mind. So here's another patient. Here's a 14-year-old boy with significant brainstem compression and long tract findings. And he had significant Chiari too. So I think there's really no other way to handle this except go from the front and the back. and that's what we did in him. This is a very interesting boy from Texas who has this Langer-Giddings syndrome, who had undergone a previous fusion, but continued to have vertical settling and vertical instability, and the fusion that was put in there was not strong enough to keep him from settling down. So he was very, very symptomatic. As part of the transoral procedure, there's 3 ways. Actually, I take that back, 4 ways to do that procedure. You could go typical transoral through the mouth with retractors. You can split the mandible in the midline. We've been doing a bimandibular split where we split the mandible on each side and drop the jaw. You can do that with or without a tracheostomy. Or people have been describing transnasal approaches, endoscopic transnasal approaches. I haven't done those personally, but I think I find that very intriguing. Most of the kids I see are, I think this would be a difficult one to do, or impossible transnasal endoscopically. You couldn't do it. So we split the jaw, dropped it, and we had to put a trach in him, and then decompressed him. And then I redid his fusion and his instrumentation, and he ultimately ended up with a very nice solid arthrodesis. Posteriorly, here's his post-operative film about 3 months later, and that's really what you want to see. After the KR decompression is done, you really want that bone to go from the occiput down to C2. So here's a variation on a theme who was an interesting boy who was 16. He had significant sleep apnea, swallowing difficulty, and discoordination. And he doesn't have occipitalization of the atlas, but he has a very abnormal occiput C1 relationship here with the C1 lateral masses anteriorly displaced. And I think this was a very interesting situation. He wasn't unstable. I decided to handle him primarily from the back. Some people may argue about how this should have been handled, and but he got much better. But his syrinx didn't go away. So I decided personally, they were really against a transoral procedure, so we went ahead and shunted the syrinx. That was before this was after I composed this slide, so what to do. So we're going to wait on this kid, which I did. I waited 6 months for him to shunt the syrinx or take out his odontoid. After shunting the syrinx, he's doing fabulously. He's completely asymptomatic, and his mom is ecstatic because he had to go through the mouth on him. So, so far so good. So those two little boxes that were on the earlier slide can be expanded now. And this is the thought process that goes through my mind. So ventral brainstem compression, patients can be asymptomatic. I've seen patients with significant retroflex odontoids, incredible end-carry malformations, totally asymptomatic. And I just watch them repeat the MRI in 1 year, or as needed if their symptoms come up. If they're symptomatic, they're broken down into two categories. One is mild, or if that Cliva C2 line is less than 9 millimeters. We talked about you can just go from the back with the posterior fossa decompression or one-stage reduction in fusion. If they don't get any better, you can always go from the front. I got a patient waiting, a 3-year-old who is coming, and he's in this category right here. And I fused him from the back, and I need to go from the front on him. If they get better, then you don't need any further treatment. If you have significant symptoms, I haven't talked about traction. There's a lot of people who would just reflexively put patients in traction. There's nothing wrong with it. I haven't done that because typically you can use the instrumentation to your advantage to reduce people. But there are many people I have placed into traction, and some people have done better and some people haven't. Sometimes you can reduce them, sometimes you can't. And after that, you're going to proceed with odontoid resection. We talked about either transoral or transnasal. You automatically, for both of these procedures, make the patient unstable, and then you go from the back and fuse them. This is my personal experience over the last, I guess it's 14 years. So I have 3 partners, so the 4 of us, we've done about 220 standard posterior fossa decompressions. I've done a little over 100 of those, and then 37 for scoliosis and syrinx, and 32 of these transoral posterior fossa or transoral and posterior fusion procedures, and that's in the context of 104 either OC2 or C1-2 fusions for other reasons. So it's a fairly high part of my personal practice. I haven't had a fusion failure in this population, knock on wood, and I haven't used any halos, and that's been gratifying. My complications, pseudomeningocele is part of the posterior fossa decompression. Is about 5% chemical meningitis. These are all standard types of things. 1 palatal dehiscence and a deep wound infection that need to be washed out, and some superficial infections, and then 2 patients with vocal cord paresis. So some of the background we're going to talk specifically about how to do the surgery. These are sort of early efforts to try. This is a rod-loop construct that we published in the late 90s, which was helpful. There's this inside-out technique, which was published in 1999, which is another nice way of creating stability and using the instrumentation to hold that occiput to C2 or C3 Aryan solidly. But you need to remember that the developing craniocervical spine is very unique in its anatomy and its biomechanics and the pathology. And these concepts that we're using to do these instrumentations are rapidly evolving. So this was a standard bone and wire technique done probably up routinely until the mid-90s, because all you had bone, wire, methyl methacrylate, that's about all you had. And then contoured loops with sublaminar cables and techniques like this, and then you start talking about various types of rods and screws and plates and so forth. So when you go from the front, the transoral resection, obviously, this is the bone that you remove. You drill through the anterior portion of the C1 ring and you take the odontoid out. So this is coming out, and then also the anterior ring of C1. And then when you go from behind, this is the initial exposure. And then it's interesting to note when you break the ring from the transoral procedure in the front and you go back and you do the C1 laminectomy, you end up with two half rings, two hemi-rings, which is a grossly unstable situation. So many times before I do the C1 laminectomy, I'll place the instrumentation, the screws between C1 and C2 to hold the lateral mass of C1 in place, so if it settles, C1 lateral masses don't splay out to the side. So, and then here we are with the plates coming out. I use a rod plate type construct. Since this bone is removed here, and you've opened up the dura, you've sewn the patch in, you shrank the tonsils down. Really, there's not a lot of bone left. Dr. Milrad also showed a very similar picture with a rod plate type of construct. And that's about all you can really do. And then you place the ribs in here. I use rib for two reasons. Number one, it's really the only bone that you can easily harvest that can stretch that far. Usually it has to be about 6 centimeters long. You can't use iliac crest. You can't make it that long. At least I can't harvest one. So 2 rib grafts side to side. Rib also has the highest content of BMP of any bone in the body. So that's another good reason to use it. And it also gives you structural strength. So I'll put a screw through the rib into the occiput, and then this is all held in place with a cable, with a titanium cable, multi-stranded cable. And these techniques are obviously very adaptable. You can put screws anywhere you want. I'm a big believer, especially in little kids, about motion segment preservation, and I try not to go below C2. And in doing this has been very successful over the years. But you can go as far as you want. But I try to stop at C2. So here's a surgical result of a patient, an early patient. So he's got transarticular screws here. Actually, the screw goes through C2. It goes into the occipital condyle. And this is what you should see. The transoral and the odontoid is gone. He's got plenty of room. His tonsils are shrunk, and he's got a nice solid arthrodesis posteriorly there. This is what you want to see. So in summary, obviously it's that these complex Chiari malformations and their surgical management, it's a wide variety of disorders that vary by a variety of findings of their signs and symptoms, how far the tonsils go down, if they have a syrinx or scoliosis, and if they have associated skull-base abnormalities or congenital vertebral anomalies. And I think that the common theme here at this conference is trying to figure out if this is a spectrum of disease or whether there's significant subgroups like these complex patients. And all of these patients are significant surgical challenges. You've got to bring them in. It's like a gigantic chess match that you need to get every single step right. And thank you for your attention and letting me share my experience with you.
Very difficult field, really changing. And c'è qualche domanda I have a question for you. Sorry. This limit that you suggest, 9 millimeter, it's very interesting, but we can also choose another strategy to perform, in any case, the posterior decompression and fixation at first, and then to see the symptoms how change, and to let the odontoid removal always as a second step operation. What do you think about that?
I agree completely. I'm a person, I don't like to have to remove the odontoid unless you absolutely have to, and I think that's a very good strategy to shift to that, to be honest, yes.
So, decision making very difficult, of course, but ci sono altre... Prego, dottor.
Thank you very much, but when you use this occipital vertebral posterior stabilization, I am surprised the urinary experience has no subluxation between C2, C3 in young patients is common. So, in my sense, preferable to stabilize one more level than you do going only on C2 to avoid the subluxation between F3, C2, and C3.
That hasn't been our personal experience. We wrote a paper that was published about 3 years ago where we followed 28 patients, 8 of which were 4 years of age or younger, for over 4 years after fusion. And 2 things were found. Number one is that we did not see instability problems or kyphosis or lordosis or any type of pathology next to the fusion level, just fusing from occiput to C2. So we were anticipating that problem, and we thought, well, we should be going further, but we said no, we're just going to stay at C2 and see what happens. And we followed these patients, and we saw no problems. Things tended to tighten up, as it were, and we didn't see unmasked instability at C2-3. So that's the first point, and the second point is between occiput and C2. Normally, you have 37% of the cervical spine growth from birth until teenage years is at occiput to C2. 37% of the growth. Patients who have been fused for 2 to 3 years, and we remeasured them after their fusions, they had 34% of the growth. So almost normal growth in patients who have fusions. So my point is that once you put the instrumentation in, the rods and the screws tend to grow and remodel around the hardware, because the bone is going to grow, remodel according to Wolff's law or just genetic predisposition, and that has been our long-term experience. So yeah, I agree. I mean, many people go down to C2, C3. I mean, I could say my personal experience is C2 is enough.
Okay.
Yes, thank you. But in my sense, when you have to put out odontoid, you have instability, but instability is only between C1 and C2. So, from a theoretical point of view, is, in my opinion, in my experience, is sufficient to stabilize C1, C2. When you do occipital, because you have to put out the posterior part of C1, you are obliged, you have not, it's more difficult to go in interarticular process to stabilize with only a graft. In this case, in very young, you should, in cases of 13 years or 16 years, I think quite different, that you go in more young patients, the stabilization on C2 exposed to the risk of subluxation with the severe consequences.
Yeah, that's true. I think that I've wondered about that too. I think it's easier said than done to, after a big Chiari decompression, to just try to get stabilization at C1 and C2 with the C1 laminectomy, with the bone. You can go intra-articular, you can put a transarticular screw in between C1 and C2, go do an intra-articular graft. I think that's very difficult to expect that patient to fuse over the long haul. I mean, that's been my experience too.
The interarticular graft stabilization is a little bit more difficult if you have dysplasia of the articular process. This is the very problem, because you have to change this attitude. But with the good anatomical surface of the articular, it's not very, very, very difficult when you have experience.
Okay, thank you very much again, Dr. Brockmayer. Andiamo avanti.